Okay, we have a plan sent to us. Very common situation. Patient walks in, tooth number 4 is broken off basically to the gum line. Patient would like to have it fixed. The options are obviously endo, post, core, crown, guarded prognosis. In the event of this situation, dentist and patient both feel that taking the tooth out and looking at an immediate implant placement was the best treatment here. So this case was sent to us to evaluate the plan done on site number 4/5. Patient's missing one of the premolars. So let's go ahead and take a peek at it. As we have CEREC data here, so we can take a close look and we can better understand exactly what is going on here. So let's go ahead and start and let's take a peek. So. All right, so if we take a look at this, one of the first things I always like to do is just kind of visualize what it is I'm looking at. And in this situation, what I like to do is I'll draw out where my bone is, or what my bone appears to be, okay, like so. I'll go ahead and draw out my tissue, which appears to be right here. Okay, and then I like to go ahead and draw out my tooth, okay, which appears to be like so. In this case, there doesn't look to be any infection or anything. So based on this drawing here, here's what I'm looking at, and here's my thought process on this, is that I look at number one, the width of this buccal plate. Okay, so I want to make sure that when I take this tooth out, that we keep the buccal plate intact. Number two, I may choose to graft this extraction socket due to the thinness of the plate right here. We know that taking out the tooth is going to cause some reaction, typically some resorption of the bone, and I don't want us to suddenly put an implant in, say, for example, like right in here, and then there's a gap here, and then we have bone resorption. Suddenly the tissue starts migrating in. So this may be a case where I look at doing a graft. The other thing that I notice is that we have the tooth goes up to here, so we know we have plenty of room here for apical extension. So I would already guess that this is a very good candidate for immediate placement because I will be able to get stability. So hopefully that thought process makes sense. So we'll make our implant up here. And again, looking at this plant, the first thing I will notice is that from my experience, I generally want to have these implants just a hair deeper. And I would probably drop this down just a few millimeters here. And the reason I want to do that is because again, I have the ability to back this out, whereas going longer for many of us is a little bit more uncomfortable. And we do want to expect some bone loss from the extraction process. The next thing we'll look at is mesiodistally. Again, buccolingually, we're pretty centered, very nicely done there. Mesiodistally, we are far enough away from the adjacent roots that we're no problem. We technically have a little more space here on the mesial than on the distal, but we want to also support it prosthetically. We'll look at a vital structure. Vital structure, we're away from the sinus. Technically, if we wanted to, we could even go up to a 15 millimeter implant. Not necessary in this case. We'll go with 13. And then we'll go to our occlusal table. And here in the axial view, it pops out to me the flaw in this plan. And that is that we have more space here on the distal than we do on the mesial. So we need to move this implant to the distal. Now, we can bodily move it, or we can tilt it. Another thing I like to do is visualize it with the sleeve. And let me back up here. So we'll go over here to the implant tab. There's a sleeve button. And now we can select our sleeve system. And when we put the Nobel sleeve in here, what we can suddenly see here also is this also is another good visual to see that we have space there. So how do we determine if we're going to move the implant or if we're going to tilt the implant? And my determination in this situation is pretty straightforward. I'm probably going to tilt this implant simply because if I move, I'm going to get closer and closer to that nerve. Sorry, not nerves, to that adjacent tooth. So my preference in this case would just to be tilt that implant till it's centered, just like so. And now we're more centered in that tooth. The next thing we want to take a look at is right here. We're coming off the buccal incline of this tooth. So we have the ability to just go ahead and tilt it a little bit that way and a little bit to the buccal. And now we're going to be more dead centered with the central groove of the tooth. And now we have a more ideal plan. And then the last thing we'll look at is our occlusal table, occlusal plane. And again, we're not off there. So just a few minor modifications. So these are the little things that make the difference between having a great plan and having a slightly off plan. So if we'll take a look here, I'm going to turn this sleeve off to a no sleeve position. Okay. And what we can see here now is our implant coming dead center of the tooth, and here is our original plan, and here we can see that the implant is off angle and slightly coming out of the buccal. So it's a good ability to see the difference, and it's always the subtleties that make a big difference. So again, thank you for sending in the plan. Hopefully this is helpful and makes sense. Last thing I want to do is go through a 360 and make sure there's no dehiscences in the bone or any areas where it gets really close. And here I'm sliding through and everything looks pretty good. This should be again, relatively straightforward, immediate implant placement without big issues. Thank you again for sending the case in, and we look forward to helping you along the way. One last thing is I keep trying to let you go, but I don't. We can see here that we actually need to move this implant back over a little bit so that it's not hitting the adjacent tooth. I wanted to point that out. Thank you very much.